I'd like to introduce you to today's specialist. So, Dr. Coleman has been with Allergy Partners of the Midlands since his completion of allergy training fellowship at the University of Iowa Hospitals and Clinics in June 2005. We're super excited to have him tonight on our webinar. Just some general background. So, before he finished his allergy training fellowship, he trained in internal medicine at the Mayo Clinic in Jacksonville, Florida, after graduating medical school from the Medical University of South Carolina in Charleston, South Carolina. So we're super excited to have him. If you know who Whit Coleman is, he graduated last year, but this is Whit's dad. He's been to USC a good number of times. He's been hard to miss, but we're super excited to have him in a different format today as a webinar. Dr. Coleman, is there anything that you'd like to add to your introduction?
No, that was pretty much how I got to where I am for sure.
Cool. Well, thank you so much for being here. So I'll just get started off with a pretty basic question of what an allergist is as a specialty. And then I also saw immunology was a specialty that this kind of falls under. So do you mind just explaining what this specialty entails and how do you get to it?
So allergy immunology is a conjoint board specialty, part of the American Board of Medical Subspecialties, and you have to become board certified in the specialty by training in either internal medicine or pediatrics for 3 years prior to entering the fellowship. The medicine and pediatric residencies are, their own separate entities that you apply for. Mine was at Mayo Clinic. Um, my current partner was a pediatric resident at Northwestern University before he became a fellow at Vanderbilt to do his allergy fellowship. So it's one of the only subspecialties that can be entered from either the internal medicine track or pediatric track, which means that as subspecialists, we treat children and adults. We also will often screen folks for immunodeficiencies or issues with how they're fighting infections as sort of our immunology clinical side of things. But we use our immunology training to help us understand a lot about our allergy diseases, a lot of our biologic therapies that are, immunology based in terms of the immune system or immune cells that we're targeting. So the immunology part of our brain is pretty heavy in terms of understanding what we're doing and how we're harnessing therapies to alter or target the immune system. So we don't get to necessarily practice immunology, say, in terms of the molecular genetics and things, but we definitely use that to help us understand what's going on, and then just have a more in-depth understanding of the conditions we treat, including eczema, asthma, urticaria, food allergy, aeroallergy issues. So those are some, like I say, immunodeficiencies come up. We have some other gastrointestinal diseases that come under our umbrella, excuse me, eosinophilic esophagitis. So yeah, we sort of have a little niche of treating those folks in both children and adults for those conditions.
Gotcha. Yeah, thank you for the pretty thorough explanation. I think you have your own niche, but it seems to be a pretty broad specialty in the sense that you look at all age groups and then it's not kind of restricted to a single body system, right? Um,
That's right.
so just a side note, if you are part of AED, please make sure to turn on your cameras. We'd love to see your beautiful faces. And then also throughout this entire webinar, feel free to use the chat feature to ask any questions. So next question. So I feel like the allergy specialty I haven't heard too much about. So would you say it's a smaller specialty or subspecialty? Or I guess are there other fellowships that kind of incorporate the same stuff that y'all do?
Yeah, we are one of the smallest subspecialties nationwide, numbers wise. Our fellowship training programs are fairly, few in number. We don't currently have a fellowship training program in the state of South Carolina, for example. The closest ones would be at Augusta, Georgia. Obviously, Duke has one. There's one down at University of South Florida. So we're definitely, a smaller group of folks, but we do treat some of the more common conditions that people deal with in terms of allergic rhinitis and asthma, sometimes listed in the top 3 or 4 of all-comer conditions in a medical practice. So the size is very small, but we definitely feel like we're impactful with the patients that we're treating in terms of the different conditions that we're seeing and the age groups that we're seeing. Um, so my practice, I'm a part of Allergy Partners, is the largest allergy private practice in the country. It has multiple hubs or sites throughout the country, um, and I think we're probably over 150, 200 physicians in total, some mid-level providers as well. And we're, I think, in over 30 states at this point. So it's one of the larger groups that we can sort of harness our, even though our size in our individual area might not be large, we can sort of harness the size of our practice and sort of help impact, our practice in terms of medical, legal, and corporate sort of administrative type processes.
So it's kind of like a franchisee type relationship in a way.
That's right. That's right. We get different practices that are independent or part of other practices looking to onboard and join us fairly routinely. We've expanded within the state of South Carolina. We're now multiple sites in the upstate, and then we have multiple sites in Charleston now. So it seems like the consolidation does appeal to a lot of people. So it's especially as allergists being such a small subspecialty, it does help us sort of practice our day-to-day business side of medicine with a lot of help.
Cool. Yeah, that makes sense. So, kind of moving on, I'd love you to talk a little bit about what kind of conditions that you typically work with. So, at what point does someone come to an allergist? Because I'm assuming you don't just see people with like pollen or grass allergies, right? At what point do they come to you?
So we actually do see a fair number of those folks. What happens is, for the most part, people can access medications that control their allergies well enough. But when their allergies are creating difficulty despite taking regular medications, and they're having trouble with absenteeism from the school or work, or they're having frequent flare-ups that create either medical bacterial viral illness, or they have just such a severe allergy flare they have to kind of take time off to recover from that. So those folks definitely come in the door either on their own or from the primary care who has already treated them with all the good available options that they have. So we're identifying what their allergens are, which can be pretty helpful for people. Let's say they just went out and got a brand new cat and now they're having a lot of trouble breathing and they're not making that connection in their head. So we can identify that with our skin testing. Um, so those folks are definitely a big part of our practice, and we can treat those folks with immunotherapy or allergy shots to help make them less allergic to those items, which also allows us, to help completely manage or desensitize them to a lot of those things that are triggering sinus issues, breathing issues, eye issues, skin issues, and those types of things. So that's one big piece of our practice is allergy shots and treating folks for those things. Another big part is those co-conditions that can be part of the atopic condition, asthma, eczema, and food allergies. So children who are born with, bad eczema and have a lot of food allergies tend to grow into middle schoolers or adults with allergic rhinitis and asthma. So it becomes and it's a fairly genetic condition. So a lot of parents have had asthma issues, maybe visited an allergist when they were young, bring their children to us. Some of them are patients of mine who have had their own children, which is kind of interesting. So we see a lot of family members, a lot of siblings, a lot of parents and grandparents who have all been dealing with more severe allergic issues.
Do you mind going into, and I know you mentioned it a little briefly, so do you mind going into the different diagnostic tools that y'all use to determine what is causing the allergy?
Right. So we have allergy prick skin testing. So there's a company that we use called Greer Labs, and we purchase extract supplies from them for testing. We have trays that are, sort of ready to go with sort of a little tiny kind of toothpick-like device resting on a tray with wells that are that we keep stocked with the extract liquids. And depending on the patient, their symptoms, what we're trying to diagnose in terms of food or environmental allergies, we prick the skin within 15 minutes. If they're allergic to those items, they'll get an itchy spot there where we're pricking them, and that demonstrates that they have IgE allergic condition, allergic reaction to that substance. So for aero allergens, it's going to be mostly eye, nose, lungs. For food allergens, obviously, highs, potential breathing problems, swelling, anaphylaxis can ensue. So people who are struggling with not knowing what's triggering their symptoms or need to confirm that it's only this nut and not these other nuts, we can prick the skin and get that information with those tests. So we have a refrigerator basically filled with trays with these testing supplies ready to go based on the history that I take from the patients that have come in.
And what would you say are the most common? So you mentioned they're extract liquids. Is that what you call them? So they're
Yeah, so Greer Labs makes extract, we call them extracts of oak, elm, cat, dog, different mold spores, dust mites, peanut, tree nuts, eggs, milk, wheat, soy. So these most common items that people are allergic to, and then we stock those, and then we prick the skin to, based on the patient's symptoms and issues they've been having.
and are there any other diagnostic tools that y'all use for allergies?
So we can't order blood tests. We don't run the blood tests. Obviously here we send them to, a local lab. So we're often using IgE levels from the bloodstream or other tests we might be looking at other, allergic conditions and other cellular components that we're checking. So we definitely have a lot of blood tests that we, are utilizing and looking at each day. If they're dealing with asthma, we can talk about getting them into a spirometer and have them blow, see how their lung function is doing. And then we have what we call a NIOX, which is an exhaled nitric oxide measurement that can look at eosinophilic inflammation of the lungs. So we can put those things together with that. So once we've done some of those things, other options would be maybe we can run some food challenges. So patients will bring in food items if we think maybe they've lost their allergy or maybe they aren't technically allergic. The gold standard of food testing and diagnosis is through a food challenge, and of course graded. So we're having, tiny bit more every 15, 20 minutes ingested to kind of make sure either we know they are or are not allergic to the food items.
Okay, cool. So I guess moving on from once you've diagnosed something, what are all the options for treatment of an allergy?
So medications are a big mainstay. A lot of folks are aware of these. They can pick them up, most of them over the counter now. Any histamines you might have heard of, Claritin, Allegra, Zyrtec, Zylol, and then the nasal sprays, which are mostly over the counter now. A lot of those include Flonase, nasal quart, things of that nature. Other symptoms controllers, your decongestants, your mucus thinners, your Mucinex, your Sudafeds. All these things can be utilized at different strengths or different frequencies to help patients. If we find out they're only tree allergic, hey, we're just going to take it February through May. If we find out they're pollen allergic to all things, we can advise on time of year to use those medications. Once they've done that, which a lot of them have before they've come to see me, then they say, well, I need to do more. I need to get more relief. So we talk about layering medications, or we talk about immunotherapy to desensitize. So by injecting the patient with the things they're allergic to at a low dose, and every 2 to 14 days, increasing that slightly, we can train the immune system to become less allergic to those items, which leads to less medication use, less symptoms, and obviously cannot even moderate their eczema and asthma issues if those are a part of their conditions. So that's one of the big treatment options that we have, medications and immunotherapy. For food allergies, we do have sublingual immunotherapy that exists for under the tongue administration of a certain item like a peanut or a cashew extract, again, purchased from, a company that's producing those. And then we administer that under observation and slowly can desensitize people to those food items. And then we have, of course, EpiPens, injectable epinephrines we need to have available for people with severe food allergies. Those are our kind of main food allergy treatments. And then we think about asthma and other allergic conditions that we see, including eczema, nasal polyposis, urticaria. We have biologic therapies, which are injectable monoclonal antibodies that have been engineered to target specific arms of the immune system that are awry in those conditions. So dupilumab blocks interleukin 4 and 13, and then we have omalizumab, which blocks IgE directly. We have other eosinophil blocking agents that can be injected usually once or twice a month, and they can sort of reduce those chemical burdens that are triggering a lot of the conditions, and then that can create a lot of improvement in patients who might not otherwise be able to achieve that with medications. Um, those are, inhaled medicines for asthma. Of course, we prescribe, your Advair, your Symbicort, your albuterol, those types of things. So those are obviously a big part of what we prescribe. Um, and then just understanding what's triggering, what can we treat, medication wise will help us tailor the regimen to the patient.
So for something like allergy shots, where you're not just treating the symptoms, but exposing them to whatever is causing the allergy, is that like, does it apply to all allergies and is it just stops over time, you get completely desensitized to it, or are there limitations to something like that?
hmm So you do have to monitor the patient for 30 minutes after every injection to be sure that there's no sudden onset of new wheezing, new hives, new swelling, new itching. So our patients get their injections, wait half an hour, and if there are no symptoms, they leave and schedule another visit for another shot. If they have those problems, then we bring them to the back and we assess them and give them medications, epinephrine injections, inhalers, nebulizers, things to kind of combat the reaction. So you do have some people who will have those reactions. Are very rare, but of course we have to be monitoring for those. Um, our sort of response rate to immunotherapy is statistically around 85 to 90% of patients who receive immunotherapy will have a positive response. There are some non-responders. Of course, that does exist in medicine, but for most of our patients, there's going to be some observe feel better. They're going to feel that improvement. Um, Sometimes the patients don't tolerate the shot where it goes into their arm. It can get a little swollen, a little painful. Sometimes we can adjust doses or take a little slower track and get them to the treatment dose. The goal is to raise the dose slowly so that we can reach the dose that's been proven to change the immune system away from the allergy side. And not everybody gets there. Some people, it's a difficult thing to get to a doctor's office once or twice a week. So some people just physically can't make it. We do have sublingual drops for allergies to the environment that some people can take advantage of if they can't get here. Studies have proven that to be also helpful. Somewhere between medicine and allergy shots, just the drops sort of fall in a category of improvement, but maybe not quite to the level of the injections. Um, and yeah, once we get through a 3 to 5 year period of that maintenance dose, the studies show that their immune system has been sort of walked back from the brink of the allergy side. And in many cases, once they stop the medications and the allergy shots, their immune systems can stay permanently altered or permanently cured, if you will. And then they can go on about their lives and have all the cats and have all the picnics that they want.
That's
We also
incredible
do
stuff.
Yeah, we also do that, I should mention, for venom allergy. So if a patient has a fire ant allergy or bee sting anaphylaxis, we can treat with the venoms to those allergens by, of course, testing which ones they're allergic to. And then we can desensitize them to those venoms, which can obviously be quite impactful for people who might otherwise not be able to be around, yellow jackets. This time of year, you see those all flying around that could potentially alter someone. You give them a really bad anaphylaxis, we can reduce that risk. So subsequent sting to someone who's had anaphylaxis to a bee, subsequent sting would be about a 65, 70% risk of a similar or worse reaction to the one that they started out with. With immunotherapy, we reduce that risk of a worsening reaction to about 3%. So it's a very effective therapy and usually is continued for a period of time determined by their initial reaction and by how they're responding to the therapy.
That's incredible. I would imagine you, based on the things that you treat, you would dramatically improve the quality of living of a number of people. Are there any like unique and or scary and or like memorable cases that you don't mind sharing for us?
Well, anytime someone has an allergic reaction in the office, to an item that we have introduced to them, either a skin test or an allergy shot, it does get your blood pumping and get you a little kind of nervous about, well, are we going to be able to handle this reaction? So those are definitely a little bit stressful times, but for the most part, with all the protocols we have in place and the anaphylaxis treatment options we have, right here with us, we can handle those situations. I'd say maybe once or twice in my 20 years, the treatment didn't seem to be improving the patient, and we would call for EMS assistance, and maybe that patient had to get to the ER. And you'll hear reports sporadically of that in the allergy community, but by and large, in terms of the thousands of allergy shots that we give, those one or two would be an infinitesimal percentage of the patients that we're treating. Um, the skin testing for some of the foods can sometimes cause some systemic symptoms, and that does get a little bit nerve-wracking when you're not expecting that. But it's usually, again, very, very rare that we see that. In terms of impact, I'm usually feeling multiple times a day or a week, positively reinforced by the impact I'm creating on the patients. Um, Recently a lady had started a biologic that I recommended that she sort of resisted for a while, and then we finally got her to a treatment plan that we were agreed upon, and her comment is sort of life is altered. I'm so happy I listened to you. Things are so much better. She's out living her life more happily. She's seen her grandkids. Her grandson's actually a medical student at Chapel Hill. She was telling me he wants to be an allergist. So, I felt like, well, at least I've got grandma sort of covered for the future allergists out there.
Yeah, that's incredible. Thank you so much for sharing. Um, is it common for people to discover new allergies later in life? Is that something
It's
that happens?
it's not as common as in childhood, but we do have many patients with adult onset allergies. I had a gentleman who was in his 80s who suddenly developed a lot of wheezing problems and asthma problems. And I, was not expecting a lot of allergies, but he was extremely allergic to cats. And he had neglected to tell me that he spends the majority of his time in his garage with his cat because his wife won't let the cat in the house, and that is why he is having so much trouble with his asthma. Um, so these things definitely come up. The impact we have on chronic urticaria with Xolair injections is extremely rewarding. We didn't have that option for the early part of my career, but these things, a lot of them have come online and been discovered while I've been in practice. And to be able to utilize this sort of real time, you know, innovations on patients in a positive way has just been really nice to see. I had no idea I was going to have those tools when I started, but that's the thing about medicine. The new tools are kind of constantly coming out, and it's just got to keep up with the literature and keep up with what's going on with the new therapies. Go to the meetings, do the CME articles, kind of see where things stand. But you have to enjoy learning that stuff too,
Right.
because it's going to always be a part of your career. I tell people if you're not thinking that you're really enjoying learning about the latest gastrointestinal treatment, maybe being a gastroenterologist might not be the right way for you to go. But if you really enjoy what's happening, with the medicine of the specialty, and enjoy how the treatments are impacting the patients, I think people are drawn to maybe surgical fixes or versus medical fixes versus psychiatric fixes. You kind of have your sort of what you gravitate towards when you learn about these things. But mine was always a little more cerebral, a little more what can I learn, diagnose, and treat versus what can I kind of cut out. That was never kind of my go-to.
So before we jump into, I guess, learning a little bit more about your journey and how you came to where you are now, I'd love to briefly talk about maybe the origin of allergies. So you mentioned that there was a genetic component. In a lot of our undergrad classes, we also talk about how allergies is or allergies are more prevalent in first world countries compared to second and third world countries. So do you mind sharing, I guess, kind of briefly just the origin of allergies? What are some factors that play into that, and maybe why first world countries have allergies as a more prevalent problem?
So we do have what we kind of use the term hygiene. The hygiene hypothesis is a big part of what, we're looking at in the allergy space. So the idea is that the immune system exists in a balanced form, as humans evolved. So once part of that immune system, the big part that treats or fights off parasitic infections is a part that's kind of awry in allergy. So IgE exists in the body to target parasitic infections. Most, if you think about the body and what's going on, most of the things there have a purpose. So survival purpose of evolutionary advantage. Why would you have IgE in your body to start with? Well, you got to fight parasitic infections, which have been a huge part of human existence, for as long as we've been around. And parasitic infection, parasites are sort of macro, larger item. They're not cells. They're not single. I'm not trying to say multicellular organisms. They're large. So IgE creates sort of a coating on a parasite and brings a lot of eosinophils to the party. And eosinophils are like little atom bombs that just release massive amounts of toxic chemicals to kill this worm or this parasite in the body. In third world countries, there's a lot of those parasitic pressures still occurring in children and adults. And so their bodies tend to stay more targeted on those parasitic infections. Whereas in more hygienic or cleaner societies, I don't know about you, but my children never had a case of hookworms or, filariasis or any of these other things. So now that we're not pressuring the immune system in that way, it can sometimes, through genetic predispositions and introduction of allergens through abraded skin like eczema or timing with certain viruses along the way, that we're thinking that these IgE responses have become sort of aberrantly targeted towards innocuous substances, foods and pollens and things that should not create an IgE response. But once the IgE is there, the patient sensitized, those IgE molecules bring mast cells and eosinophils and all these other cells to the party wherever they're recognizing these molecules. So for pollen, pest, dust, mold, just upper and lower airway. For food allergy, it's gastrointestinal, and then massive anaphylaxis throughout the body. So that aberrant IgE sensitization seems to have an occurrence because of this lack of balance with the sort of normal path through life evolutionarily that we all probably used to do, that we have more recently evolutionarily not been exposed to. A couple 100 years is not really an evolutionary pressure. Maybe in a million years we will have fixed ourselves, but at this point it's still an aberrant response to what should be an innocuous substance. Food allergy got worse when we combined eczema patients with food avoidance, which was a recommendation that was made without knowing exactly what was happening. Now that we've corrected that and said, hey, don't avoid foods when you're young, especially if you have eczema because your risk is higher. Recent articles suggested that we prevented probably around the order of 40 to 50,000 cases of peanut allergy in the last couple of years just by changing those recommendations. Again, new data that's come out while I've been in practice that has, been able to impact the practice of allergy significantly, while I'm doing that in real time.
Do you mind talking a little bit more about food avoidance? What was that something that I guess physicians, or it was like a recommendation at some point for younger populations to avoid certain foods?
It was. So basically in certain cultures, people feed their kids sort of standard items. Well, my grandma fed me this, and so I'm feeding my kid that, or my mom gave me this, I'm feeding my kid that. Different cultures feed their children specific item, just what's there. So like in China and Israel, they feed a lot of boiled peanuts and peanut puffs to their children. And in Britain and the United States, for example, we feed a lot of peanut butter, which is a dry roasted high heat peanut product. Once you've heated something, you're really changing, you're denaturing those proteins. again, molecular biology there. So if you create this sort of allergenic substance and then you either feed it or you have it in a child intermittently where they're not regularly ingesting it, you can sort of prime the immune system to become more allergic to those foods. And there is a sort of immune tolerance window in childhood that will close, after like age 5 or 6. So if we told people for a while not to eat peanuts until they were 3 and they had horrible eczema, the theory was, well, they're probably getting peanut protein through the eczema without, because peanut is a pervasive part of our culture. And then they were avoiding it. So we were just basically making the allergy worse. And now by saying, let's don't do that, we're showing on statistical studies that we're reversing the study. Those recommendations were not made based on data or studies. They were sort of consensus recommendations. So a lot of times experts in a field would get together and say, what do we all think, makes sense to recommend to people in these kind of consensus recommendations. But if you drill down into some of those, you look for like the evidence, they'll sort of tell you the evidence quality, but the recommendations based on, is it based on quality A, B, C, D data? You'll see a lot of times there wasn't a lot of data there to start with. It was just people who kind of decided based on their experience, this might be a good thing to do. So those original avoidance recommendations were consensus recommendations. Now we have the data to say, obviously those were wrong. I'm not sure who was in the room that day, but hopefully they've learned their lesson.
Yeah, thank you so much for sharing. I think that was a perfect synopsis on all the contributing factors to allergy and the origin of it. I'd like to transition to your journey up until this point. Is Was the allergy subspecialty something that you were always interested in? And do you mind sharing, I guess, your life path up until this point? And feel free to start wherever you think is the most relevant.
Well, I'm from a really small town in South Carolina. So my father was a farmer, my mother was a school teacher. Um, Town had about 2,500 people in it. Um, so I just always kind of had this, small world view, when I was a kid. So then I decided to apply to and attended the Government School for Science and Math in Hartsville, South Carolina. And of course, scientific study there was definitely different than what I'd been, had experienced. And the rigor there sort of taught me, well, I'm capable of rigorous academic study and I'm interested in medicine. Maybe I can combine those two skills. Um, I think it was a good sort of litmus test for me to say, can I push myself into this sort of more, academic rigorous field? So once I left government school, USC honors, continued that, path and was, successful, of course, straight A student, all that sort of stuff. Did well in MCAT. Um, you just keep building those blocks. Well, do I want to take on this next challenge, take on this next step that's necessary for this next phase? And you kind of have to take a bit of a leap of faith. I didn't know when I took the MCAT how it was going to turn out. I just had to kind of study hard and have confidence and do my best. And so that was, how it turned out. And kind of had always thought about being in medicine. I'm not sure exactly why. I did see an allergist when I was a kid. I did take allergy shots as a kid. So I was around, a physical human allergist as a kid that maybe a lot of people are never around. Without a fellowship in the state, most of the trainees in this state who go through Prisma Health or MUSC, a lot of them never ever even meet an allergist. It's not a required rotation. It's not something that everybody has to study. Um, so part of what I'm doing in these forums with you guys is getting the word out. Here's an allergist, it exists, and here's what he does. So, but I was always a little bit interested in it, to be honest. Once I got into my internal medicine residency and realized that I liked sitting with people, talking to people, uh, you know, getting a history, touching people, examining them, and then impacting them with treatments. As an internal medicine, it was, I was doing a lot, but I didn't feel like I was really bringing that quality of life, that you spoke of earlier. I felt like it was a little bit more of a, deck chair rearranger. How much longer can we keep this patient alive if we change from this hypertension, antihypertensive to that antihypertensive? How much less, uh, you know, vascular disease can we create by getting their sugar under better control? It was always very interesting, but I never really felt like I was changing the course of the patient's disease the way I could as an allergist. Is really go in and sort of alter the immune system and sort of fix something that was aberrant to start with. And molecular biology was always one of my favorite subjects. My immunology courses in medical school, I loved. I think Whit was telling me he's not such a big fan of the immunology courses, but it just, when something clicks, it's just like this clicks with me. I can see it in my head. I'm a big sort of mental image type person, bit of a photographic sort of just if I've seen it, I can kind of remember it type person. So it was just all very appealing to me. I try not to get too deep in the weeds with my patients on those side items because their eyes sort of glaze over a little. But if they look like they're interested, I'll take it as far as they'll as far as they'll let me. Um, but then I wasn't sure once I did residency. I did go to some national meetings. There was a meeting near me in Orlando of allergists, College of Allergy, the Academy of Allergy, the sort of uh, professional organizations within the specialty, and just to be in a room from people all over the world, who are all focused on allergy as a resident. I thought, well, this is a real thing. Like these are a lot of people out here who do this and impact people. Um, Meeting other fellows and residents in the specialty. It was just really nice to sort of say, hey, this is a viable thing and I enjoy it and I can be in this space. So then you have to apply to fellowship. You have to match now. I was not in a match situation, but now most fellowships are matched. So once you've matched the residency, then you can match into fellowship. Again, each step was, will I achieve this? Will I get the match? Will I make the grade to the next step? Um, and then I did. So now to be honest, I did want to go to the Medical College of Georgia from Charleston to Georgia. I was not necessarily aiming for Iowa, but that's the spot that I was awarded in the interview process. And so that's where I went for my training. But the information that you get from a training program, by and large, is going to be similar whichever part of the country you're in. It's just a matter of who's looking for who and what qualifications and whatnot. So once I got to the fellowship, spent 2 years there. Most of the fellowships are 3 years now. A lot of them have a research year, which I didn't have to complete, but a lot of them do that now. Um, and then, being from South Carolina, it's like I kind of always saw myself practicing in South Carolina. And so once I made that decision to leave Iowa, um, it was, coming back and finding a practice. And Allergy Partners was expanding at the time. The guy that's now retired that I worked with, he needed a partner. He was getting busy, that type of thing. So then I came back here and been kind of been kind of doing this ever since '05 for 20 years.
So just wanted to get a summary of the timeline here. So it's 4 years of undergrad, 4 years of med school, and then was internal residency 3 years?
Three years. So depending on the residency, it could be more than three. I think OBGYN's four. I think general surgery's five. You can subspecialize in different surgeries. But then you have other residencies that are specific to the specialties like dermatology is its own residency, radiology is its own residency, pathology is its own residency. But they're all usually somewhere in the 3 to 5 year range. Your general big three, your family, your peds, your internal, those are all 3 years.
And
And
then
that's where the, yeah.
how long was the allergy subspecialty?
So the allergy subspecialty training is going to be pretty much three now. When I was in it, they were sort of transitioning between two and three, trying to figure out how to, because we weren't sort of so sort of across the board clear on how each fellowship was going to be designed. So it's a little more standardized now is what I'm looking for. But at that time, they were still accepting people for 2 years, and that was the one I ended up in. So I guess you could say I kind of got away without a third year of training that most people will probably need to complete at this point.
And do there exist any residency programs that combine internal medicine with allergy, or is it always like you have to do internal or pediatrics and then subspecialize?
Yeah, it's going to be that way. There's not going to be too much combining like that. Yeah.
Okay, cool. At any point, Are there any adversities that you faced, and how did you overcome that? And you mentioned you also came from a really small town as well.
Yeah, I mean, I, I don't know that there was a lot of adversity. Just the personal toll of studying and being, under stress during either difficult exams or difficult hours in training, just volume of information, just struggling with, am I going to learn enough? Am I going to be a good enough doctor? Am I going to be able to handle my patients' problems, adequately and correctly? Um, and so I think that was always the biggest kind of concern I had. It was, I don't really feel like I struggled either, financially or academically. I always had a strong support system around me from my family. Um, I met my wife in college, and we've been together for 27 years, met over 30 years ago. So um, she's in medicine, she's a PA. I mean, I've always enjoyed that support system. Um, you know, I think if you've got some people around you that are your support, when you're having those struggles, you can always lean on them for those support measures. Um, but just I feel pretty blessed. I feel like everything has always kind of that I've reached for has worked out, and so I don't take that for granted. Um, but I really don't know that I have a horrible struggle story that really would fit into that category.
No, it's totally fine. Thank you. So there's two questions that we've asked all of our specialists that have been on here. The first is if you were to, I guess, sell your specialty to us, try to convince us to either explore the specialty for shadowing or pursue it, what is something that you would tell us to convince us?
So I think a lot of what I've kind of mentioned up till now, I would kind of put together. The things I like about it are the getting to see all ages. I saw a 2-year-old today, and I saw an 88-year-old today. So I like to see different ages. I like to be able to impact all age groups. And also, if you just see one age versus the other, sometimes it can get a little bit monotonous. So it's kind of nice to mix that up. Um, I think that the hours are a big part of the appeal of my specialty, where we're pretty much 8 to 5 Monday through Thursday and 8 to 12 on Fridays. Phone call maybe now and again with a question about something, nothing major. I'm not on staff or shift in any sort of hospital, ER, that type of thing. And I think as any specialist, the reimbursement is going to be higher than a general practice. So that's just sort of standard across all subspecialties, cards, GI, we're all going to get, the coding is built that way. The same code, that I bill as a specialist, I get paid a little more than people who bill it who aren't specialists. That's just how medicine works. So that's a nice perk that have that extra reimbursement. Um, I think that it's a very cerebral subspecialty. If you're interested in learning about new things, and you're interested in how your treatments are actually working in the body and how that's impacting the patients, sort of a bit of an internal reward. But I think that's a big part of why I enjoy what I do, is that I have this sort of really clear understanding of it. Um, those are sort of my big selling points. I think that yeah, lifestyle, reimbursement, and the medicine you practice are sort of the three tenets of any area that you're in. And you need to sort of be comfortable with all three of those to feel, I think, content in it. I don't think you got to be honest with yourself of whether what rank those are in that's going to make you happy with that area of medicine. But I think you need to be honest with yourself about those things and what happiness that brings you based on those, so that you can achieve that. And if it's more towards reimbursement or less towards hands-on, or that don't that's your business. That's your happiness quotient. Don't let anybody else kind of tell you it has to be one way or the other. Just kind of go with what's gonna give you that contentment, because you're gonna have to do it for a long time. You're gonna go through a lot of training, a lot of headache, and then you're gonna practice it for hopefully at least 20, if not more years. Um, so you don't want to sort of go with any type of other person's idea of what it is that you should be doing. You need to really be thinking about it for yourself, and just be really honest with yourself about when you're sitting there doing it, how are you going to feel about it, and are you going to be happy with it?
That was perfect. Thank you. So the other question that we've asked all of our specialists, and before I ask that, the last 8 minutes of this webinar is going to be Q&A. So if anyone has any questions, please put it into the chat. I'll go in the order of which we get those questions. The last question that we ask all of our specialists is, so the healthcare and medical field seems to be pretty challenging. Starting in undergrad, there's a lot of commitments you have to make, and it tends to be pretty challenging even as a practicing physician. So how are some ways that you cope with those challenges, burnout, stress, and also just balancing CME on top of your personal life?
I think that balance is just something you kind of build into your psyche all along. Like you said, as undergraduate, you've got this meeting we're in now, you've got your homework, you've got your classes, you're already juggling your time to achieve the most that you can where you are. And you just take that into each new scenario, each new area, and just keep applying those same balancing skills. You're going to prioritize. I really want to hear what his allergist is saying. I'm not going to go to this other meeting. I'm going to not study this X amount of time because this other thing's more important. I think you have to make those priority decisions in your mind so that you can make them and you can live with them and be happy with them, and not constantly second guess yourself or worrying about that. Um, Balancing is easier in my subspecialty because, like I said, the hours are such that lends itself to that balance. But if you're sort of someone who's more pleased, or when you're driving, when you're active, when you're grinding, so to speak, um, you know, find this area that brings that to the table. Burnout definitely is an issue. My practice has sort of a like a burnout coach, like physician coaching is a thing now, where they'll kind of help you maybe examine what you're doing and how you could change that or reprioritize that. Um, I just never let that part of me get too far into the wrong direction. Um, yeah, I've had other doctors sometimes along the way say, "Hey, you're supposed to be doing X, Y, Z. You're not supposed to be doing this other thing with your kid." I was like, "Well, that's your opinion. It's not how I'm going to live my life." Yeah, you gotta do what's going to work for you, and it might mean giving up some things, or living something else out, but it's only 24 hours in a day, and you just design it to where those 24 are the best that you can make them.
Are there any particular hobbies or I guess things that you go back to anytime you're stressed or burnt out? I guess like anything important in your life that you use to stay balanced.
Well, I do go to the gym every morning. I've always felt that helped me stay mentally sharp, and my stress level is always better when I've been, done my hour. That has to be at 5 a.m. for me. Doesn't have to be at 5 a.m. for you. I think being active is helpful for your physical health, your sanity, and your stress personally. So I think that's always something that I, utilized. But just family time, movies, sitcoms, you know, that type of stuff's always been a big part of my relaxation. Um, just being with my family, being with my kids, just just having that sort of thing at the end of the day that I'm working towards, has always been just kind of how I design my time. Yeah. In terms of other stress relievers, maybe I'm just more laid back kind of guy. I don't know that I really don't get all that stressed out, I guess. Just tackle a problem, figure out where to put it on my schedule, and deal with it as it comes. but the days I don't exercise, I get a little more a little more anxious. So I guess that's how I've managed it all this time. I'm not sure, but I guess that would be my answer.
And I think a good point you made is kind of being intentional with your time. So having priorities and prioritizing health if you need it, or prioritizing something else if that is something that you really want to pursue. So I think that was a great point. So we have a couple questions in the chat, so we'll just breeze through them real quick. First one was, what do you find to be the biggest challenge to treating allergies today, if anything?
I think medicine always the challenge is the affordability aspect for any patient. The treatments can be incredibly expensive at the specialty level, and so trying to figure out ways to access those treatments for all of your patients equally, I think is one of the biggest challenges. Bureaucracy and sort of the corporate level billing and all of these things. I don't deal with a lot of that. So now kind of that's by choice why I joined this type of practice. So when I get off this call, I'm going home. I'm not going to do payroll or something. So I think I've figured out to build all that into my schedule already. Um, but allergy as a practice, I think just the sheer size of it, the fact that a lot of people don't know what we do, you want to try to match what you do with the right patients, and that can be challenging to get the right patients in that you can be able to help. So I think that's another kind of big challenge of allergy is a lot of people don't know exactly what we do. They might come in for the wrong reasons. And of course feel bad that, they're there, but that's another kind of challenge that we face, I would say.
All right, and our next question is, how do you build trust with patients who may be anxious about their allergies?
Well, I think my demeanor goes a long way towards disarming people and talking to them plainly. I try to look them in the eye. I try to make sure that, I'm listening to their questions and concerns. I try not to talk over them. I try to ask open-ended questions and listen and just get points of clarification. And sometimes people are saying things that I know aren't relevant, but I might let that part kind of come out and then focus on something else so I can get the right information. I think most of my patients sort of realize in the first couple of minutes that I'm there to help them. I'm there to figure out what's wrong with them. They may not have been listened to clearly or taken seriously in the past. And so I'm there to kind of say, well, no, you're here for an allergy issue and I'm the allergist. So let's get to it. Um, and I think they definitely just get that trust from the interpersonal communication and the sort of sincerity about, what can if they're there to be a little bit just kind of complain, or kind of tell me what's wrong. I do sometimes struggle developing a relationship with some of those patients, but if they're there and I'm basically on the other side saying, well, how can I help this? Let's fix this. Then that seems to be, a big bridge trust builder.
That makes perfect sense. And then one final question, how did you maintain a growth mindset while in undergrad and or med school?
I think it's part of my personality to just continuously see what I can do next. Like I said, being from a small town, when I got to each place I was, in my mind, I was not going to be as good at the thing as the other people. And I kept proving to myself that, hey, I'm as good or better at this thing than all these other people. So stop thinking I'm from XYZ small town or I'm so and so from such a place or such a family that I can't be as smart or as good as anybody else. That's just not true. So you just keep going for it and proving to yourself that you're capable. And then, well, what can I do next? What can I build on here? While also staying true to my core values and to my priorities that going to kind of keep me sane for the rest of my life.
Perfect. Well, thank you so much, Dr. Coleman, once again for being here. Are there any final remarks, words of advice that you'd love to leave us with?
Oh gosh. I feel like I've just been speaking constantly for an hour, so I think I probably said enough.
All right. Well, thank you so much. This was super helpful. Me personally, I knew nothing about the allergy specialty, but I think I have a very good understanding of what allergies are to begin with, but also a lot about the specialty and how to get into this field. So we appreciate you
Good.
sharing. Does
That
anyone
was
have
my
any other?
goal.
Yeah, that was perfect. Thank you so much.